Okay. Got it. Wait.
Cool. Hey,
so
thank you.
This seems good now. Okay. So I just want to make sure the poll is working. So it says, why is that doing that? Okay, so is our poll working? There's no poll in there. So if I go to share the screen, that was the one thing we were having kind of an issue with.
Yeah.
I mean, I have it up here.
The YouTube link?
Yep. So if I just went to my YouTube link right now, oh, that's going to work, right? Or no?
Yeah, it should.
Can you see it?
No, I can't.
Okay.
Did you hit the picture of the screen that has a single red line through it?
Yep.
Yeah.
Okay. So it says enter screen, but it won't. My share button's off. It won't let me hit my share button. So I don't think I have access.
Okay, let me see if I do, because I need to share this PowerPoint when folks join. So,
hello everyone. Hello. You should have access. Are you saying when you hit the share, you can see your windows come up, but you can't share the button?
Right.
Matthew, are you able to?
I just
my share button, you know, it's
hang on for MaryJo. Yep.
Blue, but it won't let me do it. Yeah.
So you guys all have the same rights. So that must mean, MaryJo, that your screen is covering up that share button. Like something's going on with the share button itself.
No, I see it right there. So there's share and then there's cancel next to it. The share, it just won't even let me.
What are you trying to share?
I was going to share the YouTube fentanyl.
Are you service announcement. Okay, so you put the link inside of the YouTube URL? Did you choose YouTube? Go to the YouTube, the little play button right in the middle, and put the share in there, rather than doing the box with the X through it.
Okay.
Do you see that option?
No, I don't.
So the options across your screen, you toggle on the mute. Right in the middle should be a play button. Yep. You see that?
Yep.
When you select that, there's a place to put a link for a YouTube video. Do you see that?
Okay, so it's the third button from the left. So when I get in there, it's, let me see. No, it's not. It's not letting me do anything. The share button won't work at all.
Okay, let me grab the video and I will play it for everyone. Welcome everyone to this amazing session. We're so glad that you are here. We will be with you shortly. Hopefully you enjoyed our keynote today. If you did, put some information in the chat. Let us know how you enjoyed it. As far as how this is going to work, anyone who's involved in this session will be able to share screen and video. Everyone else will be able to have conversations with you within the chat space. So right now we have our facilitator, MaryJo. We have our main presenter for the session, which is going to be Matthew. And then we also have a video that we want to share with you that talks about fentanyl by StaceyJProductions. And so let me see if I can share that so we can get this session started.
Also, I'm a big movie guy, so the internet provides that opportunity where you get access to a whole bunch of movies. In fact, I just saw Space Jam. It's okay. It's cute. So it gives you the opportunity to see movies, and especially now.
So MaryJo, do you want to take it from here?
Yep. Thank you for being here. That's tough to watch, and we're here so that we can stop that from happening. I'm happy to introduce Matthew Yascolt, who is the State Opioid Response Grant Coordinator in the Substance Use Disorders Department at DWIHN Integrated Health Network. DWIHN Integrated Health Network was awarded the State Opioid Response Funding in 2019 as a measure to reduce overdose deaths related to opioids in Michigan, which are of epidemic proportion. The State Opioid Response Grant is a comprehensive program constructed to combat the surge of opioid-related overdoses, tailored to encompass prevention, treatment, and recovery services.
The red box.
Prevention services have a two-tier approach to prevent the onset of addiction in high-risk population groups and to prevent fatal overdoses through the distribution of Naloxone. Treatment services address the onset and progression of opioid use disorder, designed to help the individual progress to remission. Recovery programs are designed to empower and engage individuals in recovery and prevent relapse. And Matthew has done many Naloxone trainings in my area and has done a wonderful job. So, Matthew, thank you very much.
Of what was going to happen.
Hey, thank you so much, MaryJo. Thank you, Nina, as well.
Okay, so we're still having
moving video that we were just shown. Really puts into perspective the danger that's out there.
So we're able to hear him.
The high potency of
find out.
Of pharmaceuticals and the instances and all the occurrences of something being presented as one thing that perhaps it's not, a consumer of drugs, be them street drugs, synthetic drugs, or pharmaceuticals. If you're buying them off of the streets, you never know what you're getting. So a very moving story. I am going to share my screen now, so bear with me for just one moment. So today we're here to talk about Naloxone, and Naloxone is the opiate antagonist or antidote that will reverse a terrible situation like we just saw. If anyone has any questions, please feel free to enter them into the chat or the Q&A section. I'm unable to access the chat, it looks like, until the end. So once the presentation ends, then we will address any questions that folks may have. But please feel free to enter them as I do the presentation. Just know I won't be able to see them until the end. So during this presentation, we'll talk about the history of the program. We'll talk about some data here in Wayne County, and then historical data across our entire nation. We'll talk about Act 462 of 2014. Talk about what an opioid is, what an overdose is, what naloxone is, and then how to use a naloxone kit. So drug overdoses affect everyone, right? They affect healthcare providers, they affect law enforcement officials, and then they, of course, affect society at large. Anyone who's paying taxes, and that's one thing that we're certainly all guaranteed to do, is being affected by the allocation of their tax dollars and by overdoses. How we decide to allocate our tax dollars affects everyone. Overdose deaths can be prevented by anyone. Lives can, of course, be saved, and it is cost effective to reverse a drug. When we first put in lives can be saved, I'm still pretty new to this position, as MaryJo said. I asked some of my coworkers, why do we put lives can be saved in there? Of course, if someone's joining a presentation and has some fundamental understanding of what naloxone is, they know that lives can be saved. He said, well, Matt, the response that we got when we first started rolling these trainings out in the community was a lot of folks would say, isn't it just more cost effective to let a substance user die from an overdose? A stigma that is still prevalent in our community. Fortunately, since then, it has started to trickle away. But you never know someone's potential. And of course, people who are using are subject to erratic and dangerous behavior to try and get their next high. But you never know their potential until they're clean and sober. I have a friend who's in long-term recovery now, and he tours the nation and talks to kids about heroin was his drug of choice eventually, started with prescription pills. But he talks to kids about what it was like when he was in addiction, how he progressed into addiction, and hopefully deters some folks from going down the same path that he went down. But he wouldn't be able to do that if it weren't for person-centered treatment, and if it wasn't for people like you out in the community who administered Narcan or just showed support, that he is now able to go and share his story and help prevent other folks from going down that path. So we all benefit from preventing an overdose-related death, our clients and our community. If there's any slide that you should take a screenshot of or take your phone out and take a photo of, I would encourage it to be this one. Michigan is the 9th highest state in the nation for opioid-related deaths and 20th for the rate. And you can see historically from 1999 to 2017, this huge spike in overdose-related deaths here in Michigan. So in 1992, a company called Purdue Pharma came up with a drug called OxyContin. They marketed it as something that was safe, a better alternative to other opioids that were on the market at the time. And most crucially, they downplayed the time release mechanism in this drug while they were marketing it to doctors to prescribe. Quite frankly, I think one of the best marketing campaigns that we've seen, because they got doctors, some of the smartest individuals here in our nation, to prescribe, quite frankly, overprescribe a dangerous pharmaceutical drug by just downplaying some of the mechanisms that were built into that drug. Needless to say, use rates started to skyrocket as prescription rates started to skyrocket. I think law enforcement were the first to notice. I remember hearing in college, pain medication, why would someone take pain medication if they're not in pain? Why would I take an ibuprofen if I don't have a headache? It didn't make sense to me, certainly at that time. Once, law enforcement noticed and reported to our legislators, we started to see great systems in place once society started catching on what was happening. So the first system we saw was called MAPS, which is now PMDP aware. But MAPS, Michigan Automated Prescription System, was able to check pharmaceuticals from going out onto the streets. So the overprescribing was able to be checked. Doctors from writing multiple prescriptions or pill mills, as you might hear of it. And it also checked individuals from going to multiple doctors for multiple prescriptions or doctor shopping. And it also checked pharmaceutical companies and put a little bit of pressure and responsibility on pharmaceutical companies for oversupplying to certain areas. I recall probably back in 2018 or 2017, a case that was heard by Congress of a small town on the East Coast that received enough units of prescription opioid medication for the populace in that entire small town to get over the recommended normal pharmaceutical dose. I believe it was like 6 units per day, which of course is absurd. So it put a little bit of responsibility on those pharmaceutical companies as well. So these systems were great. They got prescription drugs off of the street. But unfortunately, basic supply and demand economics, we had a demand for something and we just took the supply away, which opens up the market for black market activity to flood to meet that demand. So what increased? Heroin use increased, fentanyl and illicit production of fentanyl, and eventually carfentanil as well. So I know I've said fentanyl and carfentanil a couple times, but for folks that might not be educated on what that is about, I think I've heard 100 times for fentanyl and about 1,000 times for carfentanil stronger than heroin. So it just takes a minuscule amount for an individual to get the effects that they would of heroin. Fentanyl is used in human application for surgeries and for hospice care, if it's elected. Carfentanil has no human application. I mean, it's not that these drugs are being deterred from pharmacies. It's that they're illicitly being produced overseas and then shipped into the United States. So much like when marijuana was first legalized in Colorado, they saw an 833% increase in parcels of marijuana seized in the U.S. mail coming out of Colorado being distributed to other states in our nation. Colorado essentially became the drug dealer of marijuana for a little while to our entire nation. What's happening right now is, from what I've heard from law enforcement officers, fentanyl and carfentanil are, of course, being mass produced and then shipped into the United States from China and Mexico. So a total of 2,686 drug overdose deaths occurred here in Michigan, 2,033 related to opioids. The death rate involving heroin is 3.5 times higher for men than women, and 2 times higher for all other opioids. The highest death rate involving heroin for young adults is age 25 to 34. And then just in general, the highest at-risk population is age 35 to 44. So a lot of folks say we're in an opiate epidemic. I think I even said it earlier, but I think they're wrong. We're in an addiction epidemic. And while there are many paths to addiction, just like there are many paths to recovery, we're currently being presented with something here in Wayne County right now that is killing more individuals than gun fatalities and traffic fatalities combined. And that is prescription drugs. That's heroin, that's fentanyl, that's carfentanil. So most recently, where were the deceased found here in Wayne County? They were most commonly found in their home. And out of the entire Wayne County populace, they are most commonly found in the Detroit area. So who were the deceased? They were predominantly male, and they were predominantly Caucasian, with an average age, as we stated earlier, of 45.2. That's the in that bracket of most at risk, which did increase. We'll look at that in a moment. So actually, here it is right now. The age distribution over time. We can see as it shifts to older age groups being more at risk. So you look, the blue is 2016 and the yellow is 2019. You can see that massive shift in age 55 to 64 of an upwards trend, and then that downward trend of age 25 to 34. So the most at-risk age now in 2019 is age 55 to 64. And of course, those folks aren't aging right over those 4 years. It's that there is now more at risk, and all of us, if there are professionals on the line, need to be aware of this data so that we can address these disparities and we can structure our programs and our screenings and however we address consumers in our area to make sure that folks in these age groups, demographics, are all being addressed and all being screened for, and educated of the dangers of overdose, fentanyl, and potentially being connected with resources, of course, if the consumer wishes. Mean ages by race and ethnicity differ. So we're looking in 2019, the youngest race and ethnicity for danger of overdose is an Arab American, and the oldest at danger for an overdose is African Americans. No surprise to anyone who knows anything about fentanyl, but fentanyl is leading the charge for cause of death, seen on medical examiners, listed cause of death. A surprise to me, and potentially a surprise to many on this call. There was a massive increase in cocaine being found as cause of death, and cocaine is the second runner to fentanyl here in Wayne County. Then followed closely by heroin, alcohol, and stimulants. Some notable trends here in Wayne County. Fatal fentanyl overdoses were predominantly younger and predominantly male. Fatal methamphetamine overdoses were predominantly younger. Fatal cocaine overdoses were more likely to be within Detroit, and fatal heroin overdoses were also more likely to be within Detroit. Just a disclaimer, this data is provisional, so subject to change, but there was a decline since 2017 in opioid-related deaths here in Wayne County, which is fantastic news. We can't attribute it to anything directly, of course, as this is just data trends. But since 2017, there's been an increase in programs. There's been more funding unlocked by multiple administrations to increase knowledge, increase access to naloxone, and therefore hopefully decrease stigma in our communities as well. On to stigma a little bit, which is certainly a barrier for folks getting help. I spoke about my friend earlier on in the presentation who's in long-term recovery. Recently asked his girlfriend of about 3 years to marry him. He got an email from his soon-to-be father-in-law saying, "I don't want my my daughter marrying a junkie." So, fortunately, he's in long-term recovery, and those words don't sting as much as they might have once. But still, in a vulnerable situation, having that sort of stigma placed on an individual could certainly be a barrier for reaching out for help, a barrier to progress in recovery, et cetera, et cetera. Oh, and also worth noting, the fear of legal risk, folks calling 911 if they do see an overdose. Folks that do that now, and they have paraphernalia on them or they have illicit substances on them, are not prosecuted for possession of that paraphernalia or illicit substance. Act 462 of 2014, if we have any law enforcement officers on the call, this gives immunity from civil liability or criminal prosecution to peace officers who purchase, own, or use naloxone in good faith. Unfortunately, we live in a litigious culture. Folks will try to sue for costs if presented with the opportunity. Unfortunately, if I were to go into an overdose right now and it took 10, 15 minutes for law enforcement to get at the scene and I stopped breathing when I went into an overdose, when I'm brought back, there could be long-term brain, nerve, or other physical damage that was done due to the lack of oxygen flowing to my extremities. So I might need to relearn how to talk, relearn how to walk, depending on what areas of my brain were affected. The person who administered the naloxone and saved my life would not be liable for those medical costs. We are all, so law enforcement protected under 462 of 2014, we're all protected under the Good Samaritan Act. So what's an opiate and what's an opioid? An opiate is the natural compound found in the opium poppy plant. An opioid is anything that's then been synthetically driven. So even heroin is not an opiate, it's an opioid because it's been processed from that poppy plant. So there are two popular theories about opioids. The first one is that we've always had opioid receptors in our brain. And the other one is that over long-term historical use, mankind has developed opioid receptors in their brain. Whichever theory you subscribe to, we all have these receptors. They're not unique to individuals that have used drugs. And these receptors are stimulated when individuals go into overdose. So stimulation typically occurs when these opioids are stimulated. Folks get sedation, euphoria, and reward. Solomon's process of addiction, for every A process, there's a B process, and that B process is going to take someone below baseline. And it's going to take a while to get out of that B process. It's a lot like what, in layman terms, might be a hangover. The only way to get out of a hangover, well, I suppose there are two ways, is to use more of the substance or wait it out. Very similar with opioids. So signs of opioid intoxication: an individual's pupils are contracted. They may appear very small. Muscles are very loose. An individual could be scratching due to skin itching. Their speech may be slurred. They could be nodding. So you could see minimal eyelid movement to extreme head movement. And they might seem out of it, but respond to stimulus, noise, or a light shake. Signs of overdose: remember, oxygen is not flowing to those vital organs. So you're going to see the visual signs of lack of oxygen, right? So blue skin tinge around lips and fingertips. And no matter anyone's complexion, you will be seeing blue skin tinge. Body will be very limp, face will be very pale. Individual could be throwing up, but really, frankly, that could be signs of intoxication as well. An individual could be passing out. You could hear choking or gurgling or snoring noises, which I like to put a little emphasis on. In 2018, I met a father who lost his son to an opioid overdose from Genesee County. And he left for work. He was living with his son at the time. And his son was just snoring on the couch. Medical examiners assume that his son passed away within about a 5-minute window since the father left for work. So for folks that work closely or live closely with individuals who are actively using, being able to recognize something as common as snoring as a sign of an overdose can be life-saving knowledge. And breathing can be slow, irregular, or stopped, or an individual could be awake but unable to respond. So facts about an opioid overdose: they usually happen within 1 to 3 hours after use, which has always surprised me. I always thought it was the Hollywood type overdose, right? What you see in Pulp Fiction. Someone uses and then bam, they're out. But really, it's a progression, particularly when the substance is heroin. Now, when you see the increasing prevalence of fentanyl, and in particularly carfentanil, 1,000 times stronger, we are seeing rapid overdose signs. But historically, it's been within 1 to 3 hours after use. So the body's ingested more of the opioid that it can handle, and it attacks receptors that control breathing. Subsequently, oxygen doesn't flow to those vital organs, and symptoms, therefore, can be unconsciousness, coma, death, and then if brought back, long-term brain, nerve, or physical damage. Naloxone, or Narcan, is an opioid antagonist or antidote. So what it does, we talked about those receptors in everyone's brain. It goes in and confuses those receptors. So here's a great visual of that. The purple is an opioid floating around in the synaptic cleft. It's been introduced into the synaptic cleft by an individual either orally taking prescription medication or counterfeit medication by insufflating prescription medication or heroin or something that is an opioid, or injecting. So it's been introduced into the synaptic cleft, and it's stimulating over and over, binding to, falling off, and rebinding to those opiate receptors. What naloxone does is it goes in and it confuses the brain. It makes it think that it is, in fact, heroin, But when it goes in and it lands on those receptors, it doesn't stimulate it. It instead sticks to those receptors and does not allow the opioid, the purple, to bind to the receptor. An incredibly important note, it does not attack the opioid itself. The opioid is still floating around in the synaptic cleft. It's just not stimulating the appropriate receptors. So it's not creating that euphoria, sedation, reward, and subsequently lack of oxygen flowing to the individual's vital organs. It's just there. So when that naloxone wears off and it falls off the synaptic cleft, if an individual has used enough opioids, they're still floating around. They're just going to rebind to those receptors. So that can cause signs of intoxication again, or potentially overdose again. So Narcan is an opioid antidote or antagonist. As we said, it reverses only opiate overdoses. It's not going to work on alcohol. It's not going to work on benzodiazepine, which looks a lot like alcohol overdose. You can't get high on Narcan. You can't abuse Narcan. It takes effect in about 1 to 2 minutes and stays active for 30 to 90 minutes. Just to reiterate, it has no effect on someone who has no opioids in their system. So it's not going to work on alcohol, not going to work on cocaine, not going to work on methamphetamine. But I'll tell you, substance abusers tend to use whatever substances they can get. Of course, they'll have preference to some, but you don't know what kind of cocktail they could be using. A lot of folks are polysubstance users. So if you encounter someone who's overdosing and knowing that naloxone is not going to hurt them and not have any negative effect, erring on the side of caution, you can always administer naloxone. And if there is a component of that overdose that involves opioids, the naloxone will work on that component. Also worth noting, I could grab some naloxone right now and spray it into my nose or into my mouth, and I would be absolutely fine. I'd have no signs of negative effect. And I'm not on opioids, so I wouldn't have withdrawal symptoms either. It would just do nothing. Here's a list of common opioids in increasing strength, from codeine to methadone. So codeine being the weakest and methadone being the strongest. We talked about carfentanil, fentanyl, and heroin. This is the lethal amount of those substances for an individual who has no opioid tolerance at the time. So of course, as use progresses, tolerance increases, and individuals need more to get the same effect that they had when they were at baseline. You can see a little ruler in this image as well. So it takes a very small amount of heroin even to put an individual into an overdose state. An even smaller amount of fentanyl and a minuscule amount of carfentanil. So just a quick overview. I don't know how we're doing on time. And I know we have another presenter, hopefully, that will join us and share a story. But if encountering someone who you believe has overdosed, just do a visual assessment first. Be aware, you don't want to just jump right in, especially with bare hands, and address the situation. If you do have latex gloves, be certain to protect yourself. But do you see paraphernalia? Are they vomiting? Are they responsive? Do they answer you? Do you see any blue skin tinge or paleness? Are they breathing? Do they have a heart rate? Then you want to call 911 first to get medical professionals on the scene. At which point, if you have gloves, roll them onto their back and do a pain stimulus test, typically done on their sternum, as you can see in the photo. The first responder has her arm out at a 90-degree angle and is pressing down with her knuckles on the individual's sternum. If an individual is not overdosing, they'll respond to that pain stimulus test. If they are overdosing, you can administer Narcan. This stimulus test can also be done below the nose and above the upper lip, but I would recommend sternum as individuals, drug users, tend to insufflate drugs, meaning they could snort them and there could be residue that could then be transferred onto your hand or glove. Here's a photo of our naloxone kits. And then within the kits are 2 4-milligram sprays. They're held as featured in the photo by the model. When being applied, this is just the apparatus device. What you see, the mist being emitted is the medication. It's all emitted at once. There's no way to just do 4 or to do 2 milligrams out of the 4 when sprayed and dispensed from the apparatuses. So full 4 milligrams. Just to touch briefly on rescue breathing, that can be done, as you know, I've said it many times now, oxygen isn't flowing to vital organs. So one way to restore oxygen to those vital organs would be through rescue breathing. Once you bring an individual back, you would certainly want to roll them into the recovery position. That would be knee bent, head supporting or hand supporting head. You really, when you bring people back, their behavior can be erratic. I've heard from law enforcement stories of administering Narcan to someone who's overdosing on a smart bus, and individual just jumped up and ran right off the bus. I've heard stories about people traditionally coming back and just being groggy, not knowing what happened. But they are in acute withdrawal as well. So they went from an extremely euphoric state to instant B process or opiate withdrawal. So being aware that their behavior can be erratic can be important knowledge to have. You can, of course, re-administer naloxone. If within 3 minutes, you can re-administer, but if you suspect the first dose not to work anyway, you can do it back to back. Don't leave the person alone. Stay with them until the ambulance arrives, being aware that they're in acute withdrawal and they may even try to use again to get out of acute withdrawal, and that naloxone wears off in 30 to 90 minutes. And finally, the last slide, addiction does not discriminate. Carry your naloxone with you if you have any on your person or near your person, because you never know when you'll need to use it. And finally, our hotline number. In instances of overdose, individuals can then oftentimes realize their behavior is problematic, and a window can open where they might want to seek treatment and get assistance to get off and stay off of opioids and other drugs. In which case they can call our 800 number 24 hours a day, 7 days a week, 365 days a year to get access to treatment. I am going to stop sharing my screen and address any questions, or of course, allow our other presenter to speak. Did I do on time?
Good. Just a few quick questions. What if my kids get the Narcan kit? I know some people have said to me in the past when you've done these presentations, I'm nervous about keeping that in my house because I have young kids.
Right. So naloxone won't have any negative effect on an individual if they accidentally came into contact with it, right? So, I keep my levothyroxine for my thyroid, I think is what that's for, out of reach of my kids, because that could have a certainly negative effect on children. But naloxone is not going to hurt a kid. It's not going to have any negative effect. It's going to affect their opiate receptors in their brain, but since they're not in an opiate intoxicated state or in an overdose state, poison control wouldn't need to get involved.
And then there was another question. Can anyone purchase Narcan?
Yeah, so there is a standing order. You could go to a pharmacy just right down the street and get Narcan. Usually it would be covered under your insurance, and purchase might not be an issue. If for some reason your insurance didn't cover it, there are many other resources to get naloxone. As a matter of fact, on August 31st, at the DWIHN Integrated Health Network offices, we're giving out naloxone for free between the hours of noon and 4 p.m. And it's just a drive-through, no contact. You just drive through, open your trunk, we'll throw naloxone in your trunk, and you can head off.
Great. And then I know that they have an expiration date on them. What about using them after they expire? What about keeping them in a hot car?
Yeah, thank you. So they are able to be used after they expire. If for some reason you're not comfortable holding on to expired Narcan, we will trade it out for a new kit with a expiration date that will be likely within 2 years. And then our mobile care units that administer naloxone out in the community from their cars, or we have a mobile triage unit that has done, I think they just hit since 2019 over 100 Narcan saves now, and they typically use expired Narcan, and it still works. Keeping them in extreme heat can certainly affect the efficacy of the medication. It might take more if it's been in 90, 100 degree weather for 2 weeks, 3 weeks straight. So do try to bring it in. Same thing if it's frozen in that dispensing apparatus, it won't be able to be ejected from it until it's been thawed. And that could decrease efficacy of the medication as well. But what I like to say, it's better to have it on you than sitting in your closet.
Right, and the kits that DWIHN gives out, you showed a picture of it. It's a small white box, but you can take the actual Narcan out, keep it in your purse, keep it in your backpack. So it's small enough that you can definitely take it with you. Another question, are you covered under the Good Samaritan Act?
Yes. Yep. So we are all covered under the Good Samaritan Act for any liabilities that might result from administering naloxone in good faith.
And just another question, I know that we had, Matthew, another time that we were doing the training, and I know you covered it, but just there's no maximum dosage of Narcan. So if you see somebody and you're not sure if the person who was, if they got the Narcan that somebody else gave them, can you go ahead and give it to them again? Is there a maximum dosage, or what would happen? Could you give them too much Narcan?
Right. Another fantastic question as well. And I think law enforcement were some of the first to figure out a lot of these answers to these questions. So I've heard stories from law enforcement officers of people that took 12 naloxone kits to bring someone back. And, they were just going back to back on those. They had extra. So that would be 6 full boxes of it. And likely it was an instance of fentanyl or carfentanil. And there's no such thing as an overdose on naloxone. It'll likely just last longer. It'll be in the synaptic cleft longer, and might take that full 90 minutes for an individual to go back into a state of intoxication or a state of overdose, which is why it's so important to call 911. I've heard plenty of stories of folks not calling 911. And sure, it can be fine sometimes, but that follow-up medical care can be so essential. We have programs with peers in emergency care settings that are there to do screenings whenever someone comes in for an overdose. They're met with one of our peers or peers that are funded from other programs that'll screen them, present them with resources. A peer is someone who's in recovery themselves, so they can be incredibly empathetic. They can, address a substance user from a different angle than many of us professionals or other folks in the field or other folks in a hospital could. So we've seen great results in referrals from peers. And there's no way someone will be able to get an interaction with a peer if they overdose and emergency medical care is not provided. Okay.
How would let's see, what area of the brain does naloxone affect?
I think in terms of cortex, I think it's one of the inner cortexes. It's not the front. It's inner part of the brain where those opiate receptors are found. But it's opiate receptors. So they're in everyone's brain. If I went in for surgery and I was administered, it's Norco now or Vicodin then, and given that for aftercare, it's going to affect me in that inner part of my brain, those receptors, or it of course will stimulate the illicit drug users receptors just at a higher rate, depending on the amount that's used.
And do you know how much naloxone would cost without insurance?
I don't. Yeah, I really don't know, but I'd encourage folks to reach out, even on our website, Detroit Wayne Integrated Health Network. If you just Googled it, or DWIHN.org, we have a form on our website where you can fill that out and have a naloxone training presented to you or your organization. And afterwards, you'd get naloxone kits delivered to your organization for you to distribute. Gosh, I don't know what it would cost without having a chance to look at someone's insurance. Typically, if it's just Medicaid, it would be covered 100%. I do know that.
Right. And with Detroit Wayne, and especially, like you said, later in August, giving out the free kits, there's so many ways for them to get them without having to worry about paying for it at all.
Absolutely. Thank you, MaryJo.
And then I know we talked a little bit about this, but how would Narcan affect a youth if they tried to use it?
It would. Okay, so if the youth were intoxicated on opioids, it would put them into opiate withdrawal. If anyone was just intoxicated, not in danger of overdose, just at a very euphoric state of using, and they were administered or self-administered naloxone, they'd go instantly into opiate withdrawal. That A process would drop right down to the B process, lowest peak of that, as a matter of fact. But it's not going to negatively affect anyone in any way if they're not intoxicated or in an overdose state.
Right. And to kind of piggyback on that, I know in other training sessions, people have asked, it does not affect somebody who has had a cocaine overdose. So, yeah. And just to get that out there again, so it won't affect somebody who has overdosed on cocaine.
Yes. Unfortunately, yeah, I think we've seen an increasing prevalence in cocaine overdoses. I know I can speak for my community. Within a year ago, we saw a devastating cocaine overdose where I believe fentanyl was involved in that situation as well. So an individual who thought they were purchasing cocaine, in fact, that was laced with illicit fentanyl.
So we need to get these kits out there as much as we can. I appreciate all the times that you've done the training on the east side of the Detroit area for the company I've been with, and we just need to keep getting these kits out there as much as we can. Absolutely. Thank you. Okay. And that is it with the questions for right now. Let me just check the chat to make sure if anybody put any questions in there. Just a lot of thank yous for the information, because this is information we need to get out there, and we need to get these kits out there. So again, what was the date, Matthew, that they can stop by Detroit Wayne to get the kits? Yeah, that is August 31st, which is in fact International Opiate Overdose Awareness Day. So in celebration of Overdose Awareness Day, we're giving out the telltale awareness and overdose prevention kits. So, and like I said, it will be contact free. So, whatever concerns you might have, you can keep your windows rolled up, just open your trunk and we'll put an naloxone kit in your car. Right. And also, you said on your website, they can go to the Detroit Wayne website to get more information and to perhaps even schedule you or somebody else from Detroit Wayne to go out to their area and do the Narcan training and give out more Narcan kits. Yes, absolutely. Great. All right. Thank you very much, Matthew. Yeah, thank you. Just one more. I'm sorry. She just wanted the date and the time. I think we said the date, but we didn't give the time again for giving out the Narcan kits. Oh, yeah. Noon to 4. Noon to 4 on the 31st. And what is the address of Detroit Wayne?
It is 707 West Milwaukee. And that is in the New Center area. And the zip code is 48202.
Yeah, it's easy to get to. It's right off the lodge. Yeah. So great way to get a free one, to get them out there. Again, keep in your purse, in your car, wherever you keep it, because you never know when you need to use it. I know somebody, DWIHN, within the past year or two, used it when she was at church one day and saved someone's life because she had it on her, and probably never thought that might have been the day or the time that she would need it, but thankfully always kept it with her. That's all the questions. So thank you very much, Matthew.
Yeah, thank you so much.
And I hope everyone, I know they received some great information. I hope they'll be by your place on the 31st to get some kits and enjoys the rest of the conference. So, thank you.